a hospice doctor, so most of my patients aren't using it for sleep. They're using it for pain or for other things. When I was doing geriatrics, occasionally, but I would say when you look at the data, it's in the top three up there with pain. It's neck and neck with pain for the most common reason people are using cannabis. And so if you ask people, a lot of them use it for sleep.
Yeah. I'm very excited to speak with Dr. Janice Makela. She is going to be teaching us all about cannabis today, which is a really hot topic, something that I get asked about all the time when it comes to sleep. Dr. Makela, thank you so much for being here. Can you tell us a bit about your background and what you do?
Sure. I'm internal medicine, but most of my career I've either done geriatric medicine or hospice and palliative care. I'm currently a medical director of a small hospice in Chicago, and I'm also recent have been moving more to teaching people about cannabis because as more and more it's become accepted and being used, I've discovered that there's not a lot of knowledge in medicine about cannabis and not a lot of knowledge in cannabis about medicine. And so I'm trying to bridge that gap a little bit.
Well,
Um,
I think it's great because, like you said, there's not a lot of knowledge about it, yet people are using it. It's becoming more and more prevalent. I get asked about cannabis all the time, both from colleagues and from my patients. I remember one time a patient brought in all these different tinctures she had gotten at the local dispensary. I'm in the San Francisco Bay Area, so it's super common here. So
Mhm.
she brought in all these tinctures and she was asking my opinion on them. And I was like, I have no idea. I don't have any training in this. I can share a little bit of knowledge that I have, but I couldn't really help her. So I'm excited that you're here and that you can teach us. Can you tell us how you got interested in cannabis?
I joke halfway in that as a hospice doctor, right? Well, first of all, in learning about the pain systems, I learned about the endocannabinoid receptors. Tylenol actually works through the endocannabinoid system. We originally thought it just worked in one spot of the brain, but now we're finding it actually works in a couple different areas to tap down pain. And even its fever reducing capacity is from the endocannabinoid system. We don't learn about the endocannabinoid system in med school, though. It's still not regularly taught. We learned the renin-angiotensin system, but not the endocannabinoid system. And so that was the first thing. My eyes were open when I learned. I'm like, wait, this does all this stuff, and it's in the brain, it's in the heart, and in the lungs, and the fat, and the immune cells. It's in all these different areas and independent of cannabis, right? But that's where cannabis works. I half joke that when I was working in the hospices, I'm an avid gardener, right? And I even grow my stuff from seed. You're in California, I'm in Illinois. I have to start stuff indoors. If I want to grow hot peppers, I either have to get them fully grown from the garden center and pay $5, $10 each, depending on the pepper I'm getting, or I need to start them from seed in February. And so I have a whole setup in my basement with grow lights and everything. And anytime you look for grow lights, there's all this joke of, oh, cannabis. And so my nurses would tease me mercilessly. Dr. Makela, what are you really growing in your basement? But it planted the seed in my head of, I do know more about this than most doctors. And so when the FDA started talking about rescheduling, and I found myself at a transition point in my career, I said, if I take this small hospice job that gives me time, I can spend some time on this and get an expertise and establish myself as an expert in the field. And so that's what I've been doing. And like I said, huge gap. I don't know about you, but for the longest time, even though I had patients using it, I thought people smoked the leaf, not the flower, right? Because tobacco's a leaf, right? And so that's the type of knowledge that even though we know about it, but I don't think that's that uncommon that as doctors, like you said, people bring us stuff and we're like, "Mm,
I didn't learn anything about cannabis when I was in medical school or residency other than cannabis use disorder. As a psychiatrist, of course, we learn about substance use disorders. That was about the extent of it. But learning how to use it therapeutically, never part of the curriculum. I didn't learn about the endocannabinoid system. So I think this is a great opportunity for us to dig into it as it relates to sleep. So I'm curious, in your work, how often do you see patients using cannabis for sleep?
Well, for me, I'm a hospice doctor, so most of my patients aren't using it for sleep. They're using it for pain or for other things. When I was doing geriatrics, occasionally, but I would say when you look at the data, it's in the top three up there with pain. It's neck and neck with pain as for the most common reason people are using cannabis. And so if you ask people, a lot of them use it for sleep. Yeah.
Yeah. What's the third? So the top three are pain, sleep, and
Anxiety. And that one, of course, is rather controversial because cannabis can create anxiety too. But when you ask people why they take it, anxiety is the third one.
yeah.
Yeah.
Well, that makes perfect intuitive sense to me because, again, as a psychiatrist and sleep doc, when my patients are using it, it's usually for sleep or for anxiety, or maybe they have a pain disorder.
There are some people who say that everyone who uses cannabis is some way using it medically. I'm not sure if I entirely agree with that statement, but there's a lot of people, like you said, who are self medicating. They're not going to us and asking.
Yeah. And interestingly, pain disorders can lead to sleep issues. It can make it harder for people to sleep. Anxiety, of course, is bidirectional to sleep issues. When people have anxiety, they're more likely to have sleep issues and vice versa. So, what does the current evidence tell us about the use of cannabinoids for these conditions for pain, anxiety, and sleep? And then maybe we can start to dig into some of the differences between THC and CBD and the different forms.
So the pain is actually perhaps the biggest evidence for. We do actually have a role for pain control where the CB1 receptor actually works to block pain in our brain here. And it actually triggers the pain blocking system in our body. We actually have a system in our body to block pain. Makes sense evolutionarily speaking. If our ancestor was running from a saber-toothed tiger and he sprains the ankle, you want to keep running, right? Yeah. And so you have a system that when you're in fight or flight will block pain. But there's other things like your endogenous opioids that can block pain, CB1 cannabis receptors block pain. And so there are other things in our body in this whole pathway that naturally will block pain. CB1 receptors work on it and is actually one of the first steps in it. Obviously, opioids are another, and they can synergistically work together. In fact, there's some studies that people who are on opioids can actually decrease the amount of opioids that they use for pain. So people with opioid use disorder who maybe do have pain and say, "Oh, but I can't come off because my back hurts," that giving them cannabis actually reduces their opioid amount. And so there's a lot of studies about that for pain. So when you're talking about sleep and pain, it makes a lot of sense. Yes, you actually have a broken endocannabinoid system. And so the receptors in the animal models, they've shown that the receptors are actually broken. When you think of Parkinson's, right? You give L-DOPA to broken receptors in Parkinson's. We have a drug to give the missing dopamine. It's the same idea with MS. This is why people with spasticity with MS respond so well to cannabis. You're actually giving them something that's broken. And then the other thing is the CB2 receptors are on inflammation. And so your C fiber pain, like your visceral pain and stuff like that, are C fiber pains. They're inflammation based. When you hurt yourself, I'm going to geek out for a second, and you cut your finger, right? There's that sharp pain, that's the A delta fibers. Cannabis doesn't help that very well. But the C fibers, which is that throbbing, aching pain you get afterwards around the injury, that inflammatory pain. So, arthritis pain, visceral pain, in things from inflammation, cannabis can actually be pretty good at. Again, I wouldn't just use it as my only drug at the end of life, but it's helpful. And when you look at data of people who are sleeping or have sleeping issues, and the data is so bad because there's no one doing standardized studies. One person does a study over here, one person does a study over here, and no one's standardizing anything. It's all, oh, this is my proprietary combination, or this is this, and this is this group of people. And so you have to try to extract it. But even in that noise of all this different stuff, it does seem that there is some benefit for people with chronic pain to sleep better.
That's so interesting too, and just to make that distinction between the different types of pain, the inflammatory pain. When you talk about cannabis, I know there's limited research or there's no standardization of the data. Are there certain forms, are people looking at THC or CBD for pain, or what's known about the different formulations?
So the THC, there there's a lot of interplay. So THC and CBD. CBD doesn't work actually on the CB1, CB2 receptors. It actually does a couple things. It works on some other receptors that modulate those receptors. And then it also decreases the degradation of the endocannabinoids. So you give someone THC, the receptors and the activation of that are prolonged by the CBD, but then also possibly some of the anxiety, some of that stuff might be decreased because of some of the downregulation of some of these other things. And because we don't have great studies on all of the endocannabinoid system, we don't know it as well as we do the renin-angiotensin system, right? We don't quite have all of that information about how they interact. We're learning new things every day, it seems. But there is this interaction. Anyway, there is data that CBD can help a little bit with pain. I would say it perhaps can help a little bit with some of the inflammatory pain. THC, the data is a little bit stronger, and perhaps it's because of what we're seeing. CBD modulates, whereas THC activates it. And then perhaps a combination might even be better. If I had someone with pain, I'd probably want a one-to-one CBD THC combo. Now, there are some people who say that CBD, for example, a lot of the studies are in these super high doses of it because that's what they did for the seizures. You actually need a super high dose of CBD to control the seizures that the FDA approved Epidiolex. Anyway, that is a long way of saying they both can help. THC, I think, helps a little bit more with some more severe pain, whereas CBD can help with a lot of more milder pain, and the combination might work well together.
That's really helpful. And I can see the role of using that for people who are struggling with sleep secondary to pain related disorders. When it comes to sleep itself, what do we know about the impacts of cannabis on sleep? So, for example, on sleep architecture. And then are there benefits for people who maybe don't have pain related sleep issues? As you can see, there's a lot to learn when it comes to clinical sleep medicine, and we're just scratching the surface in today's interview. If you are a physician or a health practitioner who wants to learn more about clinical sleep medicine in a practical way that you can use in your everyday clinical work, then get my free sleep mini course. I'll put the link to that in the video description below. You can also get it at intrabalance.com/doctors.
That is a good question because what we see in the studies, again, nothing standardized, but when they try to do different things, when you ask people, did you sleep well on cannabis? They say, oh my God, I slept great. When you do actually the sleep studies on them and you look at their sleep architecture, you find out probably not as good as they think they are. You have a little bit more light sleep. You might wake up a little bit more. Yes, you're going to fall asleep a little bit faster. Yes, with THC, you might stay asleep. You might have a little more trouble waking up in the morning, right? But it's going to not necessarily be quality sleep. Your REM's not going to be great. And there's some studies to show that people who are chronic users out of the addiction world and stuff, you get people who are using it, maybe addicted to it, using it every day, going through withdrawal, or even before they do, they find they have increased REM latency and decreased sleep efficiency. So they're not sleeping as well. They might not be dreaming as much. Then when you withdraw, you actually get insomnia. And when you do sleep, you might get a lot of dreams. It's part of what can make it very hard. And part of the reason we should have a little bit of caution when talking about using it for sleep. The question is, are you using it for sleep because you really need it? Or are you going through withdrawals? And if you don't use it, you get withdrawals. And now you have insomnia from the withdrawals. It's a real question.
I think that's a great question. And it's definitely something that I see in my practice when people are using cannabis regularly, especially THC regularly. They get REM suppression. And so when they stop or they try to wean down, they get REM rebound. So they get this rebound of REM sleep associated with these vivid, disturbing dreams and insomnia, like you mentioned. And so it makes it really hard for people to get off.
Conversely, it's not always a bad thing in certain circumstances. PTSD, one of the studies out there was showing that it can inhibit nightmares. So when you have the bad nightmares with the PTSD, cannabis can actually decrease it, which then makes sense because we're talking about how it's actually decreasing your REM sleep. So, of course, if you have less REM, you're going to have less nightmares.
And really interesting to look at some of those clinical applications. And with regard to PTSD, is there anything known about the form, like you mentioned, the 1-to-1 THC CBD ratio for pain? Do we have that kind of data around recommendations yet?
Not really. I mean, I think I, a lot of the PTSD, to be honest, because the VA doesn't prescribe it, has been self prescribed. So, what you end up with is a lot of veterans who have PTSD who are self medicating with smoking cannabis.
Okay.
So, I don't think the data has been quite that granular as to what is the best combination for PTSD.
So we talked about pain-related sleep issues, PTSD-related sleep issues. Are there any other specific indications that clinicians should be thinking about?
Well, I would say they talk a little bit about anxiety, but anxiety is a double-edged sword, right? An interesting thing I read was there was a couple studies on CBD and sleep, and the data on CBD and sleep really doesn't support it as much. It doesn't seem to do as much for sleep. But there was one where people had anxiety and like they took the CBD in the morning. And I want to say almost that by decreasing the anxiety, they maybe slept a little bit better with the CBD. But again, it wasn't used as something to help you sleep. They weren't taking it at bedtime. There's again so many early things. Restless leg syndrome, there was some question about that it might help a little bit. Maybe some of the, I want to say THCV, which has some benefit in Parkinson's, might help with restless leg. And here's the really weird one. And I wouldn't say don't stop taking your CPAP and start smoking marijuana, okay? Or cannabis, right? I would say that this is interesting. Obstructive sleep apnea actually gets better with THC. And that blows the mind because it's like, what? You would think that, oh, it makes you lazy and tired and all these stereotypes of how that your throat would be more prone to it. But no, because we're thinking like a barbiturate sedative, right? Where you're just less relaxed. No, for some reason, sleep apnea actually gets a little bit better on it. Again, do not throw out your CPAP and start smoking cannabis. And the other thing is, I will say the data about primary insomnia is not great. As we talked about it, it does hurt the sleep architecture. But as a geriatrician, behavioral disturbances and dementia are another thing. There's been more and more data that very low doses, we're talking at a dispensary, if you just say, yeah, give me a gummy, it's more likely than not going to be 5 milligrams. But 2.5 would be the next dose. And I'd probably do a half of a 2.5, a 1.2 dosage for someone with dementia to start them off on. I actually had a patient whose family said, oh, I heard this might help. And they gave them a gummy, and I have no idea what dose. I just know the patient slept for a day and a half. So you want a low dose, but that can help with the agitation with some of the sundowning. And I'm like, Seroquel or trying a little cannabis? Maybe, right? Trazodone. When you look at your choices, benzos on the beers list, no, no. When you look at your choices for sleep, cannabis in certain patients might be a better choice. But for dementia, certainly I might try that a little bit sooner than I used to. You said you haven't prescribed it too much for patients. You get asked what's your experience and what you've seen with that.
Absolutely. So, I mean, most of my work is around insomnia. That's what I specialize in my practice. And I see the people who have now developed a psychological dependence on various remedies, whether it's CBD or melatonin or supplements or, of course, medications as well, like Ambien, Trazodone, all of those things. So a lot of the work I do is helping people navigate away from that dependency so that they can
Right?
restore their natural sleep. I'm working with somebody who they've been using CBD for years and it helped them initially. And they felt like it helped with their anxiety and it helped their sleep. But now there's this great fear of letting go of it.
Mm.
Traveling now, oh, I can't travel to these different countries because they don't allow cannabis. How am I going to
Mm.
sleep? And so now they've developed an anxiety and fear of being without it. So
Mm.
that's the area that I work on with people using CBTI, cognitive behavioral therapy for insomnia.
I was going to say, because that's
Yes.
the number one evidence is that cognitive behavioral therapy for sleep is like 1A recommendation.
Yeah.
I think a lot of times the people that need the medications, like in the cannabis world, are more people who have a problem already with their endocannabinoid system. And then that balancing it can help. We talk about CBD and THC, but there's also some other ones out there. There's a lot of buzz about CBN right now, which is a minor endocannabinoid. The thing with CBN, though, is like when you look at the data, it's not great. It's like it doesn't hurt you. There doesn't seem to be side effects or withdrawal or any of those other things. Like the studies I've looked at, there was one study that compared it was a placebo, melatonin, CBN at 3 different doses. And it worked as good as melatonin. And there was no dose difference, which really had me scratching my head. I'm like, no dose difference between 25 to 50 and 100. I'm like, you should have seen some dose difference, but no dose difference. And no difference between melatonin and melatonin. It's hit or miss. Some people really respond well to it. Some people even get a little snoozy if you give too much of it. And some people it does nothing for. And it's the same thing with the CBN. There's some people who it helps and some people who it does nothing for. That said, if someone was talking about what can I use, and it would probably be for general insomnia. It would be on my docket of things to consider and to say we could try it and see if it helps. As far as pain, there was actually another thing. There's PEA, and don't ask me to pronounce the actual what that is. It's related to the cannabinoids. It works in that family. It's not necessarily on cannabis, it's cannabis adjacent. And it has some studies about that with fibromyalgia. That it's actually had a couple studies about fibromyalgia. It helps them sleep if you have fibromyalgia, because again, decreasing that inflammation. So, those would be 2 things that I might consider before actually recommending cannabis. Though I would think again, MS, straight to the THC. Dementia, a balanced 1-to-1, very low dose. Cannabis for sundowning would be the 2 things.
I'm curious then about the different formulations. There's gummies, there are sprays, there's lozenges, there's all kinds of different formulas, there's vapes. So what can you tell us about using those different forms and are there advantages to some over the others?
Something that as doctors, we don't know. We don't have cannabis drug reps coming in showing us, look at our newest, right? In fact, I really only learned it when I had a friend from church who had cancer and I was making the cannabis runs for her. And here I am, a doctor asking the bud tender, can you tell me what's what? Right? But it's something we don't learn, right? And so there are, first of all, as a doctor, strongly discourage people from smoking. I think we can all get on board with that. While the long term side effects of smoking are not as bad as tobacco, probably because a person's really only smoking a joint a day, 2 at the most, versus 20 cigarettes a day when you smoke a pack, right? Just the sheer amount of stuff you're smoking. At the same time, yeah, it's just not good. And as a hospice doctor, I really do appreciate when my patients don't smoke right before I visit them because it's in the air and it's just not a good thing. Same thing with vapes. Vapes are just smoking light. Vapes, of course, were responsible for the popcorn lung years ago, where they put vitamin E in the vape and then people started getting serious lung damage. So I'm still just a little, I'm like, no. Then I would almost rather have someone smoking like a whole plant than doing a vape. Then there's gummies, and that's probably my go-to. And probably one of the more interesting things about gummies right now is gummies take an hour or two to kick in, but there are nano emulsified gummies now, which means that the THC molecule is surrounded by little fat missiles, right? Little pockets of fat. And that and they make it really small, and that is being used a lot in the beverage world right now to help it dissolve in water because cannabis doesn't actually dissolve in water very well. So all these cannabis beverages are being used that way. But clinically, it also means that the gummies that are made like that are fast acting because those tiny little fat capsules get absorbed really easily into the gut. And so the time of onset is closer to 10 minutes instead of 2 hours. So you now have rapid acting gummies. But be aware that you could have these rapid acting, you can have these slow acting. And so if you see stuff that's nano emulsified, fast acting, then there's like dabbing and stuff. And that's really more in the recreational area if you're doing the dabbing. And then there's another thing way people will sometimes do it. I've seen some doctors called vaporizing, where it's not vaping, but you're taking the flour and you're heating it so that all the volatile chemicals come off of the flour, but you're not actually burning it. And then you can inhale the air but you usually need a device, and that device can often be quite expensive. Yeah. And I forgot extracts, like you said, the concentrates or the actual tinctures. Tinctures can be very good if you're very sensitive to taste or if you're already having nausea or something, like if you have chemo. I have a friend and she was getting the chemo, and the taste of the gummies just made it worse. So I got her a tincture. And the tinctures, again, can be fairly fast acting and are also a great go to. There's also another type of liquid called RSO, you may hear, Rick Simpson oil. It was an old traditional thing used way back in the day, but it's still out there and still often considered for medical cannabis. But the doses of grain of rice, they say, give yourself. I'm like, who can measure that? I am not a fan of that for that purpose. But yeah. So tinctures or gummies,
Great.
depending.
What about topical applications?
So topical application, this is a debate. I actually believe that topicals have benefit. I've debated a colleague in the field on this one. He's no, it's all placebo. I'm like, we have cannabis receptors on our skin, and they do interact with the pain receptors. So I personally think, at the very least, as much as a Lido patch, which also is working topically, right? It doesn't, there is transdermal and there's topical, right? And so transdermal, of course, would go into the skin and into the blood. There are some people working on transdermal applications of it. I'm not sure why you would do that. At that point, why not just take it on any other route? Because the transdermal is not going to be very reliable. I mean, as we know with like transdermal opioids, it's a little bit of a guessing if it's working or not. But topical, I've had a number of patients when I was doing geriatrics who came to me using topical THC for back pain and knee pain and had really good success. So I'm for it. If it works for you, use it. I think there's a little bit more data for THC versus CBD on that. But yeah.
A question I get a lot from colleagues is about substance use disorder, cannabis use disorder. What are the risks if someone is using cannabis for these different indications that you mentioned? What are the risks of them developing cannabis use disorder around it or addiction around it? And then the second part of the question is for people who do have a history of addiction or substance use disorder, should we be avoiding cannabis? You mentioned that it can be useful for people with opioid use disorder. So yeah, what are your thoughts on all of that?
So, first of all, if you're using it every day, you are at risk of addiction. I think that's fair to say. Now, especially right now, I talked about the different ways things are available. We talked a little bit about dosages, and where I'm talking like 1.25 or 2.5 milligrams, right, is what I would start at. You go to a dispensary, a lot of what you can find is like really high dose these days, 50, 100 milligram doses. I'm like, that's too much. I saw one that was actually in the medical end of things, 100 milligram gummy. And I'm like, ooh, ooh, ooh. Maybe that's what my poor patient who slept a day and a half took, 100 milligram gummy, right? And so you have to be very savvy about that. Second, when you're taking it every day like that for something, I think there is a little bit of a risk. I think the data about chronic pain and stuff like that, much like with opioids, right? One way I view it, and I actually learned this from when I was doing my sickle cell rotation like 20 years ago in med school, right? Was 25 years ago, was an attending once said, and this is back in the day when we had Dilaudid and all these kids with sickle cell were getting addicted to Dilaudid and wanting it. And it's like, how do you know if they're wanting it because they're addicted to it or because they really are in a crisis? And she said something that stuck with me, which is, are they using it to get through their life or to live, to do their life, to live their life? Or are they living to get the pain medicine? Right. And that there's a difference. So that functional, if you're taking it every day and it's getting you sleep and you're able to function because your fibromyalgia is better or because your PTSD is better or anything else, right? Then great, fabulous. I do have a gripe, and as psychiatrists, we might disagree on this. I do have a gripe with the DSM-5 redid how it viewed addiction between 4 and 5. And it used to be dependence was a separate creature than addiction. So caffeine dependence, right? That if you had withdrawal symptoms or if you had tolerance, that was dependence. And that was a different creature than addiction or use disorder. And now they've combined it. And so now if you have addiction and you have dependence, so tolerance and withdrawal, then you're considered mild cannabis use disorder. And I'm like, that doesn't quite seem right because then all the other ones are like, you're not working because you're smoking weed or you've estranged from your family or you're using it despite risks and to your health. Those are huge, big problems. And if you're doing that, yes, but physical dependence, I don't. That's my gripe with the DSM-5. So when we talk about that, I think it's important to separate out people who have daily use, who might get withdrawal, who nonetheless are living a very healthy and happy life, versus people who are living for the drug. And I think that's when we talk about addiction. Now, and again, there is actually some data, people who say they're using it for sleep. There may be that addiction and that overlap that we talked about at the very beginning, I think is real, that there are some people who are now using it for sleep who actually are going through really bad withdrawal and probably do meet the diagnosis for moderate or severe CUD that you are working with. That's a whole different creature. Yes, there is a risk to that. Are you going to see that risk in an elderly patient as you use it for probably not as much. Cancer patient, probably not as much, right? Now, but you get into that gray area when you're dealing with the veteran with PTSD who's been self-medicating or the person with MS who's been self-medicating, where they probably do need it, but then where's that area? There can be that gray area right there. Now, opioids. Yeah, there's some studies to actually show that you can help people come off of opioids with cannabis. And that's actually been more and more researched, which is kind of cool, actually. So, alcohol, I've not seen as much research about getting people off of alcohol. In fact, I might be a little bit, if a person had a history of alcoholism, especially if they're already controlled. I'm not sure I would want someone who is prone to addiction to be on cannabis. I mean, one of the things it does do is activate dopamine receptors, which is why it can help Parkinson's a little bit, right? But activating those dopamine receptors, that also means you're prone to addiction. So if someone has addiction behavior like alcoholism, it's probably not the best thing to be throwing cannabis at them. Another group of people I would not is anyone with schizophrenia, right? As you well know, bipolar. I think the data is increasing that schizophrenia is actually a disease of the endocannabinoid system. In fact, omega 3 makes an endocannabinoid in your body. I don't know if you knew. And anyway, and that can actually help improve that. So there's this kind of balance. Sorry.
It's so fascinating. There's just so much to learn and so much more research to be done. No, and it's really interesting about the endocannabinoids. There was a study a couple of years ago on a meditation practice that is shown to increase anandamide, which is Sanskrit. Ananda means bliss. So it's like the bliss
Yes, I
molecule
know,
with an
right? The
endocannabinoid. Yeah,
first
it's so fascinating.
endocannabinoid. And I love that and I hate that at the same time because the fact that they call it bliss, it's yes, it is a good feeling chemical, but it really does so much more. It's really more about regulating your body. And it really unfortunately feeds into the stereotype of, oh, it's for getting you high. It's no, it does so much. Like there's studies about neuroprotection. You have it in your brain, and that when it might prevent, it might help development of Alzheimer's. Of course, these are all animal studies, and every animal, right, is cancer free, Alzheimer's free, right? When by the time you throw drug X at it, right, and then it doesn't translate to humans, but there really is some data to show that there's a neuroprotective role of it. There, it's in your lungs. Cannabis can actually bronchodilate a little bit. There's all these nice potentials, and we just need to research it so much more.
Fantastic. Well, thank you, Dr. Makela. I'd love to have you back anytime to dig into this more because I think just as clinicians, there's so much more for us to learn. I learned so much just now in our conversation. What would you like to see change with regard to how clinicians are taught about cannabis and how they counsel their patients?
Well, the first thing I really wish is that just the endocannabinoid system itself was taught more. Again, we have this whole concept that the endocannabinoid, because it has the word cannabis in the name, right? When they first researched it, they said, oh, look, cannabis activates it. So they named it the endocannabinoid system. But it has nothing to do with getting high. It has so much to do with our metabolism regulation. It's on fat cells, it's on immune cells. And it's a lot of our chronic conditions that we have are often because the endocannabinoid system is not balanced. I wish people knew more about it in general. And then I wish they knew that when people have a broken endocannabinoid system, when that balance is off, and that, yeah, cannabis, you give them more. There may be a future where this is the digoxin, right? We have the herbal medicine that's been used forever for the heart to get the fluid down, the digoxin. Now we know there's this fine balance and it's still used, but not as much because we have better drugs. And there may be a future where we have better drugs. But right now, with them not researching it and not looking at things, this is a great thing for some people who need it.
Well, thank you again. If people want to learn more about you or work with you, where can they find you?
I have a web page. It's my name, Janice Makela, MD. I'm also on LinkedIn. I'm extremely active on LinkedIn. And I'm in the Chicago area. I'm, like I said, a medical director of a small hospice. If anyone needs hospice, you give me a holler. I do have a Q&A live stream on Wednesdays right now at 3 o'clock. I'm live streaming on LinkedIn because I have a lot of followers there. Twitch, because Twitch turns out is very canna friendly. I can talk about it without being banned. Facebook, I can't, so I'm not on Facebook. And YouTube. So any of those, and they're all on the channel Janice Makela, MD.
I'll put all of those links in the video description underneath this video. So everyone go follow Dr. Makela on LinkedIn. I'll put her website down there as well. And let us know in the comments what your biggest takeaways were from today's discussion.
Thank you.